Gupta. Puneet Gupta has a practice in Ghaziabad, and as a solo practitioner, I can say he is the he has the latest generation machines. Only surgeon in northern India to do an endoscopic surgery. Very well versed and a person who will always stimulate you to learn, learn, and learn. Dr. Puneet Gupta.
Thank you, Avninder, for kind introduction. Thank you for including me in this interesting instruction course. Good afternoon, everybody. I'll be talking about OCT angiography in relation to age-related macular degeneration. I'll be talking about a little bit about the background of OCT angiography in technology in relation to AMD, utility of OCT angiography in diagnosis and management of CNVM in the OCT, and also diagnosis of CNVM in non-AMD because they are the differential diagnosis. In my opinion, AMD is one retinal disorder where the potential of OCT technology is best utilized and gives practical clinical information which is translated into clinical use. So this has already been discussed by Dr. Avninder in detail, where various NFAS maps of vascular patterns of different layers are created and represented on the screen. And along with the NFAS, in addition to NFAS, slab-based NFAS angiogram, OCT data can also be viewed on cross-sectional flow cross-sections, and the flow data is superimposed on that cross-section images. This is very important to differentiate the lesion. The yellow color here demonstrate the flow in various layers. These are the pictures of Heidelberg machine. This is the area where we focus in age-related macular degeneration patient. This is avascular complex, and this is choriocapillaris, and this is choroidal area. So this is the area where the most of the activity in age-related macular degeneration occurs. To generate an image on OCT, there has to be a minimal amount of flow within the vessels to create a differential image. If there is no flow, the OCT angiography will not create an image, and this is very important in detection of choroidal neovascular membrane. OCT has been demonstrated to have high specificity and sensitivity in detection of choroidal neovascular membrane in various layers. All kinds of choroidal neovascular membranes can be very effectively detected on OCT angiography, whether it is type 1, 2, or 3. In neovascular AMD, because the retinal architecture is very much disturbed, it is the automatic segmentation of the layers is not very reliable. So you have to use the custom segmentation slab to locate the flow within the lesion. This is the custom slab which you move over the lesion to detect the slab in the NFAS image. So by reviewing both NFAS and cross-sectional OCT together, it increases the specificity and sensitivity of detection of choroidal neovascular membrane if you compare it to the NFAS image alone. Segmentation should be correct to locate the choroidal neovascular. If you see in this image, this area, the segmentation line is dipping below towards the choroid. So actually what you are seeing here is not a choroidal neovascular membrane, it is actually the choroidal vessel which is showing the flow here. So the diagnosis of choroidal neovascular membrane in this scan is not correct. So this is type 1 CNVM where you see the membrane which is below the RPE. This is type 2 CNVM where you see this membrane which is lying above the RPE. The membranes can be both combined or mixed, where that means there can be type 2 combined with type 1. PCV, the gold standard for detecting PCV is still considered ICG, but since ICG is not available everywhere, OCT angiography and OCT images can also be utilized to detect PCV pathology quite reliably. The flow in the thumb-like PED at the tip of thumb-like PED with a double layer sign, along with it having a branching vascular network, is an indication that there is a possibility of PCV. It is generally difficult to pick on OCTA due to poor flow in the polyps. These polyps that are present in PCV, they do not have good flow. That is why OCT angiography is not a first choice of detecting flow in PCV patients. But if you combine it with cross-sectional images, there are chances that you will be able to detect the features of PCV by which you can make the diagnosis. But still, ICG angiography is the gold standard. In non-exudative CNVM, this is an example of a vascularized drusen, where you can have flow within the drusen, and this can only be detected on OCT angiography. It is missed on fluorescein angiography and OCT. Another scenario of non-exudative choroidal neovascularization is quiescent choroidal neovascularization. That is also found on OCT angiography. The difference between the vascularized drusen and the quiescent neovascularization is that the vascularized drusens grow vertically, whereas the quiescent neovascularization grows horizontally between the layers. Both these situations may develop exudation at a later date. 20 to 80% of the non-exudative CNVMs, they eventually convert to exudative choroidal neovascular membrane, and they need close follow-up, but no treatment is required until they develop exudation. So detection of these non-exudative CNVM, which can only be possible effectively on OCT angiography, is important. Similarly, in patients with whom you are treating, the patients with neovascular AMD, the fellow eye examination is also important. These fellow eyes may have neovascular, these non-exudative membranes which may be missed. In this patient, this is the first image of OCT where there is some atrophic changes, but if you see here carefully, there are some SHREM areas and some activity here. On angiography also, some flow is detected here. And this patient developed the exudation, and the flow is detected on OCT angiography. So this is another interesting patient. This was a 60 years old lady with 6/9 partial vision in both eyes, some drusenite type of changes, drusen changes in the outer retina. And on OCT angiography and OCT, you can see some drusenoid PEDs, but no flow was detected in this patient. This patient developed some hyporeflective spaces, and it looked like a serous detached, some fluid within the retinal layers. And subsequent OCT also, this hyporeflective space increased, and this patient was given anti-VEGF injection, but there was no improvement in vision or fluid. This was the OCT angiography, which showed no choroidal neovascular membrane. Again, the OCT angiography was done. That also showed no flow signal, and subsequently also the space increased, but there was no flow at the on OCT angiography. These are some reflection artifacts, but not exactly the flow. So this was actually the adult onset vitelliform dystrophy, where the vitelliform material has absorbed and is giving an appearance of fluid within the retinal layers. There was no CNVM or flow on OCT angiography. This is the other eye picture of the same patient. So OCT angiography is also a reliable tool for confirming the absence of choroidal neovascular membrane in neovascular in retinal disorders. Now, the management of follow-up of these patients, OCT angiography is very helpful. These are the sequential photographs, and if you treat these patients with anti-VEGF injections, these vascular fronts, they get they change in shape and their vascular pattern. The maximum regression of these vascular fronts, the capillaries and the branching network, they occur at 2 weeks after the treatment. The reproliferation and reopening of the previously closed choroidal neovascular membrane is again noted by 4 weeks. So all these features are helpful in managing your patient, how the patient is responding. Though till now we are managing all our choroidal neovascular membrane patients, neovascular AMD patients, by assessing the fluid. We are not using the biomarkers of OCT angiography for managing these patients. But these things will come up as our understanding of OCT angiography develops. Now, these fronts can be active and non-active, or you can say immature or mature. The active fronts, they appear like densely packed nets of C fans and with extensive branching. There will be extensive branching in active lesions. The extensive capillary sprouting and numerous anastomosis can be seen in these active lesions. Whereas once the choroidal neovascular membrane gets matured, they become larger in diameter, filamentous vessels with lesser branching and lower capillary sprouting. And this maturity develops after almost about 6 months of anti-VEGF treatment. I'll skip this dry AMD slides because I'm already. Uh, so one important thing I want to convey is for proper quantification of choroidal neovascular membrane, proper quantification and proper detection of choroidal neovascular membrane, segmentation should be correct. If your segmentation is not correct, you will not make the correct diagnosis. For that, you have to sit on the machine and diagnose the things yourself. There are limitations. Dr. Amrinder has already explained those various artifacts and limitations, but still, OCT angiography has high diagnostic value in detecting the presence or absence of choroidal neovascular membrane and is a useful and dependable tool in management of neovascular AMD. Thank you.